All right, great. Thank you all so much for joining us this evening. I appreciate it.
Thank
Thanks
you
for
for
having me.
having me on the
Yeah,
show.
thank
Yeah.
you.
Absolutely. All right, so Jackie, we're going to start with you before we dig in. If you wouldn't mind just sharing a little bit about your journey with your daughter and how that led to your current passion.
Okay, yes. So my daughter, who's now 7 years old, she was born at 38 weeks via C-section. We received the postnatal diagnosis of Down syndrome. And what that means is during my pregnancy, we didn't know that we were going to have a baby with Down syndrome. We did have soft markers for Down syndrome, which later on with an ultrasound, the results per my OBGYN were unremarkable. So, we didn't know until she was born. And so for your listeners that don't know what Down syndrome is a genetic condition that involves either a full or partial copy of the third copy of the 21st chromosome. So also known as trisomy 21. It's the most common type of Down syndrome, and that is what my daughter has. And so the main trait that comes with the diagnosis of Down syndrome, and it's the first time I learned about it, is when she was born, and when we got the confirmation of the diagnosis, is hypotonia. So now I know, as a myofunctional therapist, what that is. We look for hypotone, tongues in particular, but that means low muscle tone. And
Okay.
so um, I use this analogy with patients now with low muscle tone and what that really means. And if you don't have a fitness background, it's kind of hard to understand what hypotone is, hypotonic. And so I use this analogy, and I want to credit Anna Gross. She's the baby SLP from the Breathe Institute. I took one of her courses. She used an example of a beanbag. So imagine a beanbag in your living room floor, okay? And just how much surface area it takes. It takes up a lot of surface area. Imagine
Mhm.
sitting in a beanbag and all the effort and energy it takes if someone to ask you stand up. It takes a lot of effort because of it's an unstable foundation.
Hmm.
That's how I describe low tone tongues. It takes up a big area inside the mouth. It makes the tongue appear large at times. And so oftentimes we
Mhm.
miss the fact that we're looking at maybe smaller jaws, to be honest, and not really looking
Right.
at the muscle tone.
Mhm.
Versus, so going back to the beanbag analogy, versus sitting in a chair with four legs takes up less space in your living room. You could stand up. The muscles that you have to engage to stand up from a four-legged chair is quite easy. So, you know, that's how what I use now, even to explain, to parents to understand muscle tone. Just takes a lot more energy and effort, where a beanbag is like floppy at rest. Normal
Mhm.
muscle tone can contract on command. And
Hmm.
so that's what I use, and that's how I understand it now. But when my daughter was born, we get assigned a social worker, caseworker at the hospital. We're given a brochure with a list of providers. It's a lengthy list, and it's very overwhelming. This is
Hmm.
the future, our future, with our daughter. And one thing I noticed is that the list, just to name a few, has providers on there like an OT, a PT, an SLP, and cardiologist. So those are a few of the providers that were on this list. And one thing I noticed that wasn't on this list is like an orthodontist, for early
Hmm.
intervention
That's
care.
huge.
Yeah,
Hmm.
it is. Or even just a dentist in general. And myofunctional therapy wasn't on there. So I feel that I wasn't, this is my second child.
Hmm.
So myofunctional therapy wasn't even on my radar. I really didn't know what myofunctional therapy was at that time. But I feel that whether it was my mama gut instinct or dental hygiene background, that really led me to believe I need to focus on breastfeeding my daughter to help her. I was thinking of muscles. So really, I was doing myofunctional therapy or trying to do it without really understanding it at that point. And so I knew this was going to affect her open mouth posture, her
Hmm.
protruded tongue, and her speech eventually.
Right.
So, as a special need parent, we are connected immediately with this type of diagnosis with our local regional centers. Usually, they're county based. So with this connection, we're given support and resources. And so at that time, our caseworker, and I want to say maybe at the age of 3, so this is after we've been through therapies. Autumn was going through therapy at the age of 3 months. We had a PT coming
Mm.
in-house weekly. So working with these providers was not new to me, and to any parent with special needs, you will understand collaborative care is important and early intervention
Mhm.
is important. That's
Mhm.
not news for us. But our caseworker at the time actually was a retired RN. So she had medical background. And when I asked her, I want to look for myofunctional therapists in the area. Can you find me somebody to help my daughter?
Mhm.
She had not heard of myofunctional therapy at all. And she has a medical
Really?
background. Yeah. So but she did try. And I think randomly we happened to attend a Down syndrome family like health fair. It must have
Mhm.
been for one of the big events like World Down Syndrome Day. And one of the vendors, this was in 2019, one of the vendors there was, well, now we know, Amanda's boss.
Mm.
And she was a vendor there, and I spoke with her, and it was like awesome. She actually understood and said, yes, I have someone on staff. I have people on staff that have oral placement therapy background or myofunctional background, and so we connected from there. And I think we were lucky that that led into 2020. So with the
Mm.
pandemic,
Yeah.
everyone was virtual, and that's how we met Amanda.
Mhm.
She was the first provider that we worked with that had this myo background, and she had that speech emphasis, obviously.
Mhm.
And I think it took maybe a year of working with her later that I decided to, pursue going into myofunctional therapy myself, because it was a high need in my area. Nobody was doing myo at that time. It seemed like, at least in our area. And that's kind of led us here today. So yeah, thanks, Amanda.
You're so welcome. I'm so honored to have influenced you that way.
Yeah,
Amazing.
absolutely.
Well, and you mentioned that you breastfed Autumn. Did you do
Yes.
the same thing with your first daughter?
So my oldest is he's my son. He's
He's a
12.
son.
And
Okay.
yes, and so it's interesting because um I am being a new mom. I think that you kind of accept the hardships that come with breastfeeding, so you don't have anything to compare it with. And with
Mm.
him, he also had some sleep disordered breathing symptoms, and I do think that I missed it with him. I have the, like, with him being 12, I'm like, oh, I just missed that window of helping him. Almost missed it. Luckily he's in expansion now, but I was able to breastfeed him. Now he was a little different. He was born emergency C-section at 41 weeks, and so
Okay.
it's with C-section, it takes longer for your milk production to come in. It takes about 5 days.
Mhm.
And it seems that milk supply takes longer, so latching was difficult. But again, you forget, because it's your first time breastfeeding. You think this is the normal, right? It's normal. This is
Mm.
what I'm going to
Right.
accept now. But what I know now, it's just because something is common does not mean it's normal, and I've learned that the hard way.
Yeah.
And most of
Yeah.
my parents that see me do. So he had a hard time latching on the left side. He had a shallow latch, which I believe to be what's a posterior tie now. um, the latch was actually ended up, I had a cracked bleeding nipple on the left side. It was very
Mhm.
painful. He was gassy, had colic. His stomach was really distended. And, again, I ended up just, kind of changing my diet. I said, okay, let me eliminate dairy. I stopped eating
Mhm.
certain vegetables. And it seemed to help. We even saw a GI specialist for him. But, we were switching bottles too, because he was bottle fed when I went back to work with
Mhm.
breast milk. But we successfully breastfed for 16 months. So I thought that we were doing great, but he also was a longtime pacifier user. He loved
Oh
using the
yeah.
pacifier
Mhm.
past the age of 2. He also was a sleepwalker. And when I brought this up to my family,
Mm.
they reassured me, oh, that runs in the family. Oh, Uncle so and so, your nephew so and so, they did a little sleepwalking too. So, and he didn't do it very much to where it was concerning to me. I just kind of accepted it and thought, oh, it's a genetic, runs in the family. So another thing too that's distinct with both my kids is we sleep train them. So they didn't have problems going down. So I think that that's why I overlooked all these little symptoms and little red
Oh,
flags
sure. Yeah, yeah.
throughout their upbringing, and they would go to sleep right away. They would nap fine. My 7-year-old was in the NICU, so when we brought her home, the nurses had her on a three hour
Hmm.
schedule, so it was pretty easy transition for her. Whereas my oldest, being a new mom, we use the baby wise method. I'm not sure if you're familiar with that,
Hmm.
but it just helps you understand the sleep cycles. So like if they
Right.
cry in between sleep cycles, to kind of let them cry it out a little bit. And then instead of jumping in and waking them up. So
Right.
it worked
Right.
beautifully for him. And I think that's why I missed it. And it's because they were both getting good amount of hours of sleep,
Hmm.
but they weren't getting good quality sleep. And
Yeah, which
that's
is
how I
huge.
right. And that's what I see a lot of my parents come in is they are getting the accurate number, required number of sleep that they need for their age, but it's the quality. And that's when we
Right.
start
It's
to
not
look
that
at
restorative.
exactly.
And it's
So I,
interesting. You said something about that with sleepwalking. You were told, it's
mhm,
common, it's genetic, and that's something that we've heard a lot of parents. They're hearing that,
mhm,
but that goes back to just because it's common to me. That's the same kind of thing. That's great that it's genetic, right? Or that
right,
everyone in your family does it. I come from a
exactly.
family where people just didn't sleep, and we wore it as a badge of honor. We're just not sleepers. 4 hours a night. You're thinking you're good. You keep going.
Right,
Well,
exactly.
you know, now I know that's not a badge of honor. And I have, kind of backed up on that and adjusted it. But I think that's really common. And I think that's something that that's one of the things they hear a lot of.
Absolutely.
That and snoring is also very normalized now. Like, oh,
Hmm.
the snoring is normal. It's in our books and it's on TV. That's what we
Right.
do when we sleep. It's not what we should be doing when we're
Yeah,
sleeping.
Exactly.
especially kids.
Mm-hmm.
Hmm.
And that's another one, right? It's so cute when a little baby snores.
Mhm.
Not really, right? But, we didn't know. We know now,
Right.
but we didn't know. So, Amanda, when you're working with and you can kind of guide me on this. I don't know if I just say special needs in general or if it's different with the different I guess subsets, like Down
Mm-hmm.
syndrome and because of
Sure.
the different symptoms that they have when you're working with them. I mean, how is that different than when you're working with a child that's not special needs? How do what kind of things do you have to look for and how does that impact therapy?
Right. So I work with children and adults with Down syndrome, without Down syndrome. And when I'm working with my clients with Down syndrome, sorry, there's a helicopter, 1 second. When I'm working with my clients with Down syndrome, I, first of all, I'm taking into account that hypotonia, that one that Jackie mentioned, that low tone, that at
Right.
rest, we're not sitting, none of our body is sitting how it quote unquote should be. And that coming from the body, from like the PT realm, like the body needs to be stable for the mouth to be stable, first of all. So that's where it's really taking the full team. So I'm thinking about that hypotonia, which also can lead to some hyposensitivity, or hyposensitivity leads to hypotonia, I should say, too. So the hyposensitivity piece is where when we are doing a motor response or when we're doing an action, we have to first sense where our body is in space,
Hmm.
sensory, and then we can respond motorically, or our brain can initiate the firing to the muscles per se. So kids with Down syndrome, and adults too, I should say, are hyposensitive, so they don't feel where their body is in space as much as I do. And
Okay.
so they take a little more stimulation to wake up the nerves per se. And that way they can then sense where their body is and react better and use the muscles. So that's where it's like, what comes first, the chicken or the egg? The sensory, the low
Right.
sensory piece. Then if we don't have sensory, we don't have our muscles being used. And then also without muscles being used, we can't build muscle tone. So it all relates that way. So I'm really thinking about the tone. I'm really thinking about the sensory. I'm thinking about how maybe they learn differently than other kids. So usually using multiple visuals, auditory, tactile, kinesthetic, as many senses as I can to cue them and help them find their placements for articulation or swallowing. And also their airway is the big one as well, because we know that their facial structure is different, and that tongue thrust coming forward isn't just the low tone, but it may be airway related. So I have to dig down deeper and see if there's something that we need to address first before we can get to the rest of the treatment, because without airway open, we're not going to be able to get that tongue in and then start our new place of speech, because where the tongue likes to rest, that's where I like to think like that's their starting point for speech. So if your tongue is low and forward at rest, then your sounds are kind of going to start here.
Right.
So if your tongue is up against the upper back molars and then lightly suctioned to the roof of the mouth, then you can grasp onto the insides of the upper back molars. I like to use my mouth. This is where our tongue should be resting.
All the way back
inside, yeah, all the way back inside on the spot, what we like to say, and then speech can start from here, where our tongue anchors against the upper back molars on the insides there, and speech can stay inside the mouth and move quickly and accurately. But if there's low tone, they're usually down on the floor of the mouth, and the tongue is not anchored and it's flopping all over the place. So inaccurate speech sounds. So that hypotonia, sensitivity, and the airway, all three really come into play when I'm
Absolutely
Down syndrome.
Yep.
So what happens, going back to that visual that you had the hand, then it went all the way, all the way back, to the mouth. What if you can only get this much of it up against the roof of your mouth?
The front?
Yes.
So if the front of the tongue is up against the roof of the mouth, well, in terms of speech sounds wise, that's like maybe good for temporary, for one sound, like your L. Maybe you have your L sound, which we have worked with Jackie's daughter too. The front of the tongue is up, back sides are down. But for a lot of our sounds, our tongue is anchored sides of the tongue, upper back, or against the upper back insides of the molars. And like that's also what I wanted to point out to parents and other speech therapists as well, is that we can't just treat the appearance or treat the symptoms of the disorder. Like, oh, your tongue is interdental when you do an L sound, let's just teach them to put it here. Oh, your tongue is out when you're doing an S sound, we'll teach you to put it in, like close your teeth, put your teeth back. That's great. And in structure, maybe they can do that when I ask them to, but when they're out and about, they're not going to generalize, because the real issue is, why is that tongue forward in the first place?
Right. Back to the root cause, which we talk about that a lot on here. And so, Dr. Peterson, and we talked about how you adjust for special needs patients when you're talking dentistry. What about things like these expanders and some of the things we've talked about?
Yeah.
Does any of that change?
It's huge. I mean, an expander is so important in these kids with speech and airway issues. And it's really interesting in the orthodontic field, because I went through residency over a decade ago. And even in my residency, there was a little talk about, oral myofunctional therapy. And it was almost kind of a running joke among the residents of like, okay, give this kid some exercises, right? Like, okay, they're not going to do it anyway. And it was never really emphasized. And then the other thing was like, there's a lot of traditional orthodontics of you don't put an expander in a kid unless they have a crossbite, right? And so, in my, career, that's kind of what I was trained to do initially. And then as I practiced for over a decade now, you start to see things in kids, and you really pick up on patterns of facial growth. And you see that in patients who have breathing and signs of snoring and speech issues, you see that they have low muscle tone, their mouth breathers, their tongue, hangs out, and you're like, no, there's something that needs to be done here. They don't have a crossbite, but they do not have room for their tongue. And then and a big part of my kind of metamorphosis as far as learning more about how this all interacts is getting a 3D x-ray, so the cone beam. Like once I had that and I was no longer seeing things in 2 dimensions, I was seeing the airway, I was seeing the arch form in 3 dimension. You can
Mm-hmm.
see so much more, and it's almost like you can't unsee it, right? And so
Yeah.
at that point, I started doing expanders early and earlier. And as I did these expanders, you would just anecdotally get these this feedback from parents of like, man, his headaches are gone. He's sleeping better. He's doing better in school, paying attention. He's speaking better. Wow, and it's just like,
Yeah.
wow, you can really see that. And so, I started doing them earlier and earlier, and also the technology keeps getting better, right? So I'm
Mm-hmm.
doing even 3D printed expanders now, which is such
Wow.
a better just overall experience for the patients because there's no spacers and there's no bands. So you need very little compliance to get it on. It's way easier to clean, and there's more room for the tongue. And so a
Yep.
lot of patients can continue to do speech therapy while they have the expander in.
And these
The
aren't permanent, right? These are ones they can put in and out. These
No,
3D ones.
so
Oh, these are
there's
permanent?
these are glued in.
Okay.
You have options of a removable. I still believe that the glued on ones are better. And I'll do them as early as age 3. I really prefer to do them later. Like, if we see a big issue like 4 to 6, but
Mm-hmm.
in a significant patient, you'll do it as early as that age. And I mean, these patients are wiggling all over the chair and you can still get it in,
Mm-hmm.
no problem, right?
Right.
Because it's just so much better for a patient, right? But um, I even have that experience with my son who's 6 and, has been in speech therapy since he was 3, right? And then
Mm-hmm.
you put an expander in and you're like, oh, well, there we go. Now you sound a lot better, right? And so, yeah, that's just been my experience.
Well, and and I know that we've heard what get to an orthodontist or have your child seen by an orthodontist by the age of 7.
Mm-hmm.
Is that too late?
In some regards, it is. So, the facial growth is 90% done by the age of 12. And there's different parts of the face that stop growing sooner than that. Like, especially a patient with like an underbite tendency,
Mm-hmm.
there's a lot of things that stop at age, closer to 9. And so, when it comes to the muscles and the balance of the structures, right? Like, what I always explain to parents is like, the sooner you get that muscle memory doing what it's appropriately supposed to do rather than the bad habits, the easier it is to undo and have everything function appropriately, right? And
Right.
so 7 is still a good age for most people, but if they have a crossbite, if they have breathing issues, if they have speech issues, then sometimes it's appropriate to bring them in sooner.
Okay. Right. And I'll put some links to some other episodes for parents who may not have heard them to talk about things such as going and listening to your child sleep at night. It sounds kind of
Mhm.
stalkerish, but stalk them, do it.
Mhm.
And don't do it just one night. You space it out because you'll start to see a pattern and you'll see, oh, maybe they were just congested that night, or oh no, it really is an issue. Um, just some things so parents can watch because at least for me, and I assume other parents experience this when they're teeny, you're with them all the time. But as they get older, you put them to bed, you go work or you watch your show or you read or you do whatever because they're in bed. It's your time.
Hmm.
So, so many of us miss these signs and symptoms that are
Right.
there at night.
Mhm.
So, Jackie, and I guess actually, really, all of you, um, when it comes to specifically, let's just focus on Down syndrome children. Are airway issues more common with them, just kind of
Yeah,
across the board?
absolutely.
Mhm.
I do have a few points, just physical characteristics that are common with Down syndrome.
Hmm.
I did get this from the CDC website, but I'll emphasize a little bit as I go along and kind of list them.
Sure.
So we talked about hypotonia a lot between Amanda and I. So poor muscle tone, which also means loose joints. And if you think of an infant or child with Down syndrome, we're talking not just the tongue. We're not just talking low lip tone, low mid face tone. We're talking whole body. We're talking organs or low tone. So, you know, with that being said, then think about the jaw joint, right? So the muscles surrounding the jaw joint don't have that strength and support, and that's why you see that open mouth posture.
Mm,
And with the low tone tongue, well, it's blocking the airway already.
sure.
So, you know, that's one point. The second point, flat faces. Usually flat faces anatomically, so that means they have smaller bridge to their nose,
Hmm.
which then means they have smaller nasal passages. It's going to be
Sure.
a lot harder for them to breathe, you know, efficiently be nasal breathers, right?
Hmm.
When we're talking tiny little spaces. Number two, short necks, you know, already that's a smaller, you know, airway.
Hmm.
We have small ears. And so small ears can lead to ear infections. And when we already have that protruded tongue sitting, you know, outside in this kind of natural tongue thrust, then they're not able to clear the ear canals properly. So it puts them they're just predisposed to these higher risk, you know, for ear infections. All of these questions are on my basic intake for any child. But, you know, I look down, I'm like, my child with Down syndrome, all of these are marked off. So, you know,
Hmm.
and there's other things, you know, that are not completely related to myofunctional therapy or orofacial muscular disorders, but, you know, tiny white spots in the iris of the eyes, small hands and feet, you know, smaller height, and also medically compromised. So, you know, our kids, because of their facial structures naturally, will have, you know, higher risk for upper respiratory diseases and conditions like pneumonia, bronchitis, COVID, you know, and obstructive sleep
Hmm.
apnea. Most importantly, obstructive sleep apnea. So yeah, it's and I feel that, you know, Autumn was her pediatrician asked me at the age of 5. I think it's kind of like a check off the list, right, for her medical chart. They do check for obstructive sleep apnea, but it literally was her asking, do you have any concerns with her sleeping?
Oh,
No.
wow.
That was it. No sleep study was done, even though I felt confident and I knew what I was doing, but nothing else was added to that screening process. My intakes for screening
Mm.
kids, typical or, you know, with Down syndrome or any type of special needs, the parents are filling out 3 sleep intake, you know, questionnaires on positions of sleep, different symptoms that will help me either refer them to an ENT to really request the sleep study, or see if they're, you know, okay to start myofunctional therapy. So yeah, we're kind of missing a little bit
We're
of
missing
that.
him.
Yeah.
Yeah.
And it's interesting because you had a real life experience that goes right back to something another guest, previous podcast, Dr. David McCarty. And one of the things he shares a story of a patient and he said, "How is your sleeping?" And he said, "Great." Well, that's just such an open
Yeah.
Hmm.
question, you know, and you're an exact case in point. You know, how is your child sleep? Okay,
Yeah.
fine. I would have said the same thing about my children, and then you come to find out, well, no one's a snorer. I didn't know. So, yep, you know, from the medical side, we need to ask better questions
Right.
as
Hmm.
patients come in. But then also, as it's been mentioned by some other guests, as patients, or in this case, parents, it's
Mhm.
our duty to come in with some of these more specifics because maybe they're not going to ask us. So you
Right.
have to be an advocate. You have to be able to say, "Hey, is this normal?
Right.
Yeah.
You know, is this okay? Or I have a concern here."
Yeah.
Exactly.
Yeah.
And so also just to kind of segue into breastfeeding and what that was like with our journey.
Yeah.
So we were lucky enough to get, you know, obviously lactation consultant help right away. I'm lucky enough to have a family that's super supportive in breastfeeding. It's not always the case with everybody,
Mhm.
but when it comes to the physical characteristics, so when we're talking about low tone and the protruded tongues, well, the latch is going to be more difficult naturally, right?
Mhm.
The
Sure.
ability to drain the breast is going to be harder. And also when we're dealing with congenital heart defects, then the endurance is not there. Already for typical babies,
Mm.
you fall asleep at the
Mhm.
breast. That's pretty common. But
Right.
when you're dealing with, you know, heart defects, it physically is hard. You know, you're going to tire out and not, you know, the endurance is just not there. So it's even more important, I think, for our Down syndrome population to get this help early on.
Mhm.
Or, and if breastfeeding is not an option, just educate yourself and, like you said, be an advocate for your child, and just maybe work with those early providers that are assigned to you right away. The OTs with feeding specialties, speech and language therapists have feeding specialties or oral placement therapies. Know what kind of cups are good to use, what cups to avoid, things like that. Little
Mhm.
small changes at the beginning. If you have to bottle feed, that's okay, but just be aware and know, your child
Certain
is not
bottles.
using certain muscles. Yeah, that's
Mhm.
going to kind of just lead them into that low tone still that we're trying
Mhm.
to improve.
Yeah.
Got it.
I can
So, and
add to that list.
yeah, please.
Yeah, for Down syndrome kids, the other things that I see is, they're mouth breathers, right? Consistently mouth breathers. And that means that they're not using that belly breathing. They're using the more shallow breathing, right? So they're not
Right.
getting that connection. But the other thing, because they're low muscle tone, they're not chewing their food properly and enough. And so a lot of those
Mhm.
kids end up having GI symptoms, right? And then they get perpetuated because as they're trying to figure out why their tummy hurts and why they're having issues, right? Then they go on different diets where a lot of them will go to like a liquid diet or a softer diet to try to correct that, right? And that's
Yep. And
almost
now we're not doing that
counterproductive.
exercise that they needed.
Yes.
Yeah.
Yes. Hmm.
Yeah.
Bits that we need there.
Yeah,
Right. Right.
All those pouch foods are
Uh,
right.
they became huge recently,
yeah.
and
Yeah.
all of us in OM are going, no.
Right. And I
I used
and
them. Yeah, I
I was
used them, and
I was about to say this is I swear just about every podcast I have to say to parents out there, all right, we've all done this. We just hit on something we've all done. So let's
yeah,
take the mom guilt, the parent guilt, let's just put it over here. You didn't know. Because
yeah,
man, I am just
Exactly.
as guilty of taking a pouch and going like this while I'm driving, or you're at the
right.
grocery store. We've
Mhm.
all done it. So it's okay. We're gonna start from where you are and keep going forward. So
Yeah.
Dr. Peterson, if you are a parent of a Down syndrome child and you're looking for pediatric dentist or orthodontist, what are some of the things you should be looking for specifically when you're going in and you're looking at their website and you're interviewing them, trying to make sure they're the right medical provider for your child?
Yeah, that's a difficult thing sometimes to find before you enter the office. But I think that the intake form, the comprehensiveness of the intake form and the questions, right? If they're asking about sleeping and breathing and things like that, you can use some of the like more sleep focused, websites. There's a lot of organizations, right, where you can try to find providers that way. I think a lot of just my experience is the moms in the community, right? That's like the best way. And, I think that here locally, we're very lucky to have like one of our pediatric dentists is just stellar and so comprehensive when it comes to this. And she's so in tune, right? And
Mhm.
so she's kind of, the word gets out quickly. But
Yeah.
yeah, finding looking on your insurance or looking on the website, it's still very tough to find people focused on that.
Sure, sure. Yeah, and it's something that I think we've all kind of run into at this point. It's hard to find just airway specific providers sometimes too, or somebody that has taken courses and is actually looking at that. So yeah, it's just not easy. So
It's hard to find speech therapists with
mhm,
that background as well. And that's just, I know what we're all advocating for is having every medical or even academic speech therapist per se having background, some sort of background and knowledge in airway, even if it's surface, just knowing what to recognize to then refer for more support.
mhm,
Because I mean, it goes unnoticed still, even by the professionals who you think should understand that. So, yeah, that's why I'm
yeah,
very happy that more and more people are trying to spread the word to look
sure.
into the airway more.
Yeah, we've even had a discussion, an internal discussion of how do you get, they already have so much on their plate, but how do you get teachers involved for the signs and symptoms to look for, because they're with our children
Yeah.
8 to 10 hours a day, and they're going to see that this particular child is a mouth breather, or when they're younger and they take naps. I mean, they're going to see some of these things, and
Yeah.
yeah, so it is all about getting the word out there.
It is. I think it gets a little bit complicated with the public education system because if a teacher is screening for something like that, the school somehow has to be able to provide a service that way. It's not as easy
Hmm.
as, they can't diagnose anything like that. So it does
Oh,
get
sure.
tricky. I
Oh,
know
yeah.
what I do with my daughter is, Amanda has a treatment plan and goals for autumn.
Mhm.
We have two speech and language pathologists. One is school based and one is through our insurance. So Amanda's through our insurance. She focuses on certain goals, and I
Mhm.
share that treatment plan and goals with her school based SLP. So then collaboratively, maybe they don't speak to each other, but they know what
Right.
they're working on, and that has seemed to help broaden like what we work on.
Hmm.
Where I'm lucky enough that Autumn gets to have a little bit of, the best of both worlds, like we get language development, expressive language, and Amanda does that as well, but we work a lot on articulation, the alveolar sounds. I want her intelligibility. I have her focus more on that aspect. So unfortunately, I know you're asking more like, how do we screen? I guess it gets a little bit,
Yeah.
sticky, but you
Yeah, not
can
even screening,
educate.
but just watching for it, because I'll tell you
True.
what, once you've seen it, you can't not see it. But
Right.
I have stood in the grocery store with my children, and you get this kind of, and they're looking over there and you're going, yes, I know that's a mouth breather. Stop. Because,
Yeah.
now that you've seen it, we're all watching for it.
Right.
Mhm.
Right.
Right.
Yeah.
And one of the
It's
things
true.
that you mentioned that I think is so huge, and to me, it just seems kind of like well, no kidding, but it's such a paradigm shift. Instead of this collaborative approach of providers,
Mhm.
Mhm.
as orthodontists and dentists and pediatricians and SLPs and myofunctional therapists all together.
Yeah.
And, you know, it, y'all are already doing that, but not everybody is kind of going that direction yet. Yeah. How do we again, it's an opinion. I understand that, but how do we get the focus moving that way? Because this kind of more comprehensive, holistic approach will allow us to get to the root.
Mhm. It takes a team. We all know that it takes a team. And sometimes we hear that word team and parents think, okay, that means like a group of professionals that I go to separately, individually, and then I relay the information from one to the other,
Right.
which is very common now. This is your team, but doesn't mean they are collaborating together as a team. And so when you take that route, you might get some progress, sure, because information is being shared, but it's not quick enough progress
Right.
or not quick progress. And also like the professionals don't, if they don't talk directly, it's the information could be, misconstrued,
Mhm.
or like
That's a
it's
good point.
misinterpreted because it's being shared in multiple ways, like telephone.
Mhm.
So that I'm really glad you brought this up, because I think inner collaboration is very important. And if you have a therapist as a parent, ask them to sign whatever permission form that you need to sign, to then have your therapist directly contact the other professionals so that they
Mhm.
can talk directly, and then follow up on that too, because I know like therapists have a lot on their plate. And I when I see a parent check in with me, hey, how is checking in with the school SLP? Um, that it's like a nice friendly reminder to me, and I also like it keeps everybody accountable to do that and actually make the progress. So
Mhm.
look for that inner collaboration and advocate for it a lot.
Yeah.
Yeah.
I typically get the help from parents. When parents come see me, I might be the third provider they've seen, And then I start asking questions about maybe their dental or who are they seeing, who's your pediatric dentist. And so if they end up, doing a therapy program, I email them so they know, hey, I'm here. This is what I'm
Yeah.
doing. And I if it's an orthodontist, Dr. Peterson and I, we have a great collaborative relationship. I work out of her office actually. But
Which is
if it's
awesome.
if I do have another orthodontist that sends me a lot of referrals for your typical kind of tongue thrust, open bite relapse cases. So it's interesting because I actually have met some providers through just like some of the other providers that my parents, the patients are already seeing, and I just make that like a way like to introduce myself, whether it's email. And some don't contact me, that's fine. Others do, and those that do wanting to learn, and I've been lucky enough to meet people that way, I think, and then they're interested and they want to learn more on how can I screen, like what do I do, who do I refer to. So
Yeah.
I end up being a little bit of the middle person, but I'm all about like I can't handle all the patients in our area. I want more providers to learn so we can help people that need it. So I
Yeah.
think the more that we could get on our team, the more awareness we could bring, and just comes
Hmm.
down to educating our
Mhm.
parents. But they really are the ones like Dr. Peterson said, it's the mom squads that are talking about you. It's so funny. I'll have some parents come in and they're like, "Oh, you also work on so and so's kid." I'm like, "That's HIPAA. I can't say," but
I can't say,
I
but
kind of wink
yeah.
at them, and they're like, "Yeah." So it's just so funny because the circle is actually really small. So
Yeah.
yeah, like Dr. Peterson said, the word kind of gets around.
It does.
And then yeah, once a parent has a good experience with having their child just thrive by breathing better,
Hmm.
they're going to talk. They're going to, and
Yeah.
it's going to be good things. They're going to want all of
Yeah.
their friends to bring their kids in as well.
Right.
Yeah.
And we call them the Airway Mama Bear Army,
Oh, there you go. I like that.
right? Because they do, they all work together and they all share. And I mean, that's what you have to do right now,
Yeah. You have to
right?
be
Which
an
is
advocate.
Mhm.
exactly, which is, why we do this show, because we have to get more of the information out there so that it's in their hands so they can advocate for their child,
Yeah.
right?
Absolutely.
In the orthodontic world, I feel like the field is about 20 years behind. And right
Hmm.
now, we're just trying to advocate for people to come in early, right? Because still the public mindset is wait for all those baby teeth to go out and then see an
Right?
orthodontist. And by the time you
Yes.
get there, oftentimes it's too late, right? And
Hmm.
Right.
you're trying to squash the narrative of orthodontists just want to do early treatment for more money in their pocket, right? Because that's the fear.
Hmm.
And so
Or
that's
if your child has teeth that are all touching when they're little, it's fine. So don't even worry about it.
right, right.
Ugh,
And
yeah.
so that's the narrative that we're still trying to overcome. We haven't even gotten really in the public mind to like, oh, orthodontists affect growth and development and airway and so much, right? There's so much more that we're addressing. But one of the things that I think is helping and what I see is all of the orthodontic conferences this year were focused on sleep. It's becoming a buzzword. I don't know
Hmm.
if any of you
That's
guys have,
wonderful.
yeah, it's super exciting, right? Because we're getting more and more knowledge, more people are debating it. I don't know
Hmm.
if you guys have seen the Netflix documentary Open Wide.
Mhm.
Hmm.
Um, but people are starting to talk about it. It's certainly
Yeah.
controversial because new information, people don't like change, right? And so
Yeah.
the word is getting out slowly but surely, but the best way is the boots on the ground, the moms. Whenever you have a parent that says, wow, my kid is thriving, I really see this, and they're the ones that live, eat, breathe, see their kids, how they function every day. You have the ability to say, okay, you now have this information, tell your friends.
Yeah. Yeah. And for those that are listening, I will put a link to that documentary as well as Heal. Both are on Netflix in the show notes. And there's some conferences like Airway Palooza, and there's a dental sleep conference in Houston. It's, I believe, dentalsleepconference.com. I'll put all those in the show notes because these are all, ones that I know. They're collaboration cures is another one. So we'll
The
put
ac-
those in the show note for people.
this weekend, the Breathe and Thrive Symposium through the American Laser Study Club is going on in San Diego.
There you go.
So
Yep.
there's
Oh, that's
another link
right.
for you. Yeah,
That's
yeah.
right. Dr. Zagi's at that one. Yep.
I
Yep.
know.
And Pinto. Oh yeah. Yeah. There's a lot of people. So
I'm getting
yeah,
some
word is getting out.
FOMO not being there.
Are you?
I am.
Are you?
Yes.
Yeah. Yeah. It should be a good one. It should definitely be a good one.
Yeah.
So usually at the end of every episode, I like to hand it back to our guests because y'all are the experts. You're the ones that have lived the journey and that are, trying to help the kids that are out there. I will leave it to you for the final word for our parent listening audience. Jackie, we could start with you.
Well, I think a lot has been said already about, just being an advocate, definitely asking questions. When you're not, you are the parent, when something is not right, and just find another provider. I think that sometimes even culturally, you're afraid, or you say the doctor is, the say all, and then you stop
Right.
there. And I think that that's not a good outlook when you're really striving to find out what's going on with your child. I tend to, if I've been if I have a patient that has been through different providers and they come to me, sometimes there is no diagnosis and I might be part of the journey of getting that diagnosis, and so I think parents just maybe even just need that guidance a little bit. So definitely find a provider or therapist that connects with your child, number one, one that is in tune with your beliefs, and one that's going to advocate for your child as well. So I think that alone can help a lot.
Yeah, I love that, being in tune with your child as well. That's huge because if there's no connection, your child's not on board.
Right, exactly.
Amanda?
Anybody else?
That rapport that's number one importance. First is the rapport. It doesn't matter what kind of therapy you're going to do. I like piggybacking off what Jackie said, start early, find the professionals that you feel like you need or connect with your child, and don't be afraid to get second opinions. There have been many times where I've referred to an ENT for airway obstruction, possibly. I can't diagnose. Same with
Right.
tether oral tissues. I can't diagnose, but we work with the repercussions of it every day. And they still it brushes off or goes unnoticed. And I say, you know what? Don't that doesn't mean it's the end. Find someone who knows what exactly to look for, find that second opinion. And don't let that, if it feels uneasy, there's still something wrong, but they're telling me that it's okay, there's probably still
Trust your
something wrong.
instinct.
That instinct. So follow that instinct.
Yeah. And I'll piggyback off of that. Getting multiple opinions is really helpful to just understand that knowledge and even know what questions to ask. But in my experience, I get families who've been to multiple consults and they're almost overwhelmed. And so one of the other things is finding practitioners that are willing to help you navigate and understand all of those different things, rather than the paternalistic approach of just do what I say is right because I know what I'm doing, right? You want to make sure, these parents, they want to make sure that they're making the best decision for their kid. And so if there's practitioners and providers that are willing to explain that and do the work of the communication, right, that's going to help make you feel more comfortable with, okay, well, we have a comprehensive plan moving forward.
That's excellent. Awesome. Thank all three of you for making time this evening to come on and for sharing your story and really helping our listeners understand just the differences that Down syndrome population is going to have to contend with when it comes with airway and sleep. So thank you so much.
Thank
You're
you.
welcome.
Yes.